बरोबर. ते बरोबर. ते याच्यामध्ये मी ते अर्धे अर्धे कट होतं दिसतंय.
Hello, sir.
Hello.
Yeah, good afternoon, sir. You're audible and visible clearly. Can you share the screen, the slides?
No, I don't have option to share the screen.
Okay. So you won't be able to share, right?
Yes.
So GGC made that slide. Hello, ma'am.
Yeah, sir. Actually, the team is joining. He'll share the screen for you. We'll wait for him to log in.
The picture टाकून
Slide and PC.
Hello, madam.
Yes, doctor.
I have slides in my PC.
Okay. So if possible, can you join through your PC then?
No, I cannot share the screen.
Okay.
Hmm.
Hello, sir. Good afternoon. Shardul here from Glenmark.
Yes. Good afternoon, Shardul.
Yes. So just give me a 2 minutes. I'll be
Actually, problem is that my PC don't have that camera.
okay. Yes. The company iPad does not allow the share the screen. That's why the difficulty is facing. I'm
Okay.
sharing the slides. Technical team, just uh, after my screen visible, just go on live now. Then
Okay.
we'll start this meeting. Okay. Yeah.
Shardul gonna hide the slide.
Yes. Just a minute. Please confirm whether my screen is visible or not, sir.
Yes.
Yes, it is visible now.
Yeah.
So shall we start?
Yes, sir.
Just a second.
Whenever you require the changing the screen, huh?
Oh,
So just give me the call. I'll change the slides.
all.
So you can just say next, so he'll change the
Okay.
slides.
Next.
Yeah.
That will
So
be better.
yes, we are live now. We can start with the session.
Okay.
Okay. Thank you Thank you, technical team, and thank you all the Glenmark. Behalf of Glenmark, I'm Shadun Mullah, District Sales Manager, Glenmark CV Division. So I'm welcoming all the delegates as well as the today's speaker. Today we have with us Dr. Akshay Shewale, sir. Sir is a very renowned diabetologist, sir practicing in Junnar as well as the Naranggaon, and sir having rich experience in terms of management of diabetes. So today, sir is discussing about this risk and screening of the diabetes in drug-naive patient and patient with comorbidities. Specifically, today, sir will be talking on this teneligliptins. So with this note, sir, I'm requesting to you, please take this session, move forward, and share your expertise about this molecule.
Thank you, Shardul. Good afternoon, all. Today we are going to see risk and screening of diabetes in drug-naive patients and patients with comorbidities. Next. So, decision cycle for the person-centered glycemic management in type 2 diabetes, in which assay key person characteristics, then consider the specific factors that impact choice of treatment, then use shared decision making to create a management plan, then agree on management plan, then implement management plan, then providing ongoing support and monitoring of emotional well-being, lifestyle, health behaviors, etc. Then review and agree on management plan. Next. Comprehensive medical evaluation. A complete medical evaluation should be performed, confirm the diagnosis and classify diabetes, assay glycemic status and previous treatment, diabetic complications, potential comorbid conditions, care partners and support tier system, social determinants and health structural barriers to optimal health and healthcare, review risk factor management in the person with diabetes, develop plan for continued care. Ongoing management should be guided by the assessment overall health function status and diabetes complications and cardiovascular risk, hypoglycemia risk, and shared decision making to set the therapeutic goals. Then, essential components for assessment, planning, and referral. Excessive risk of diabetes complications, that ASCVD and heart failure history, ASCVD risk factor and 10-year ASCVD risk assessment, staging of chronic kidney disease, hypoglycemia risk, assessment for retinopathy, neuropathy, muscle, and MASH. Goal setting, the set A1C, blood glucose, and time in range goal. Set lipid goal. If hypertension is present, establish blood pressure goal, weight management and physical activity goal, and then diabetes self-management goals. Then therapeutic treatment plans, that is lifestyle management, pharmacological therapy for glucose lowering, as well as cardiovascular kidney disease, risk factors, weight management with pharmacotherapy or metabolic surgery as appropriate. Use of glucose monitoring and insulin delivery devices, referral to diabetes education and medical specialist as needed. Referral for initial care management, that is eye care, fundoscopy, family planning for individual of child being, then registered dietitian, then diabetes self-management, education and support, dentist, comprehensive dental and periodontal examination, behavioral health professional if indicated, audiology if indicated, social worker and community resources if indicated, and other appropriate healthcare professions. Then the next slide, please. 360-degree model for diagnosis. Previous slide, please. Previous slide. So screening of diabetes patient with comorbidities, autoimmune diseases like type 1 diabetes for autoimmune thyroid disease. Then type 1 diabetes should be screened for celiac disease. Then measurement of vitamin B12 levels should be considered for people with type 1 diabetes and peripheral neuropathy or unexplained anemia. Next slide. Then bone health, assess fracture risk if older adult with diabetes. Then monitor bone mineral density. Then consider the potential adverse effect on skeletal health. Then avoid medications with known association with higher fracture risk. And then reduce the risk falls and fractures. Glycemic management goal should be individualized for the people with diabetes, a higher risk of fracture, prioritize use of glucose lowering medication that associated with low risk hypoglycemia to avoid falls. Next slide. Cognitive impairment and dementia. So, meta-analysis of prospective observational studies found that the individual with diabetes has 43% higher risk of all types of dementia and 43% higher risk of Alzheimer dementia and 91% higher risk of vascular dementia compared with the individual with diabetes. Then analysis with accord action, diabetes and vascular diseases, pre-directs and diamicron MR controlled the evaluation, advanced affairs diabetes, intensive glycemic management, that is A1C goal should be less than 6 or 6.5, resulted in on diabetes cognitive outcomes compared with the standard control. Then type 2 diabetes and dementia are higher risk for experiencing hyperglycemic crisis. And then metabolic dysfunction associated steatotic liver disease and metabolic dysfunction associated with MESALT, that is MESALT. In this screening of adult with type 2 diabetes, metabolic dysfunction is associated steatohepatitis, that is MASH, using calculated fibroscan 4 index. Then adult with diabetes, persistently elevated plasma aminotransferase levels for more than 6 months and low FIB4 should be evaluated for other causes of liver diseases. Adult with type 2 diabetes or pre-diabetes with a FIB score 4 or greater than or more 1.3 should have additional risk stratification by liver stiffness measurement with transient elastography. And then enhanced liver fibrosis, and higher risk for significant liver fibrosis, gastrointestinal or hepatologist, consult a gastrointestinal or hepatologist. Next slide, please. The 360-degree model for diagnosis and treatment types. The 360 model depicts shift from glycemic strategy to uh, glucocentric strategy to vasculocentric strategy to manage diabetes. So, in this glucometabolic, then psychosocial health, immunometabolic status, vasculometabolic status, viscerometabolic status, and baronutritional status. So, next, we can see first glucometabolic status, in which target-oriented activity, that is fasting plasma glucose, postprandial glucose, or glycosylated hemoglobin. In this test are needed are self-monitoring of blood glucose or continuous blood glucose monitoring, that is CGS. Safety-oriented activity, that is glycemic variability, hypoglycemia, or time in range. Vasculometabolic status, in which there is a cardiovascular and microvascular health. Cardiovascular health, there is atherosclerotic cardiovascular diseases or congestive heart failure. Atherosclerotic cardiovascular diseases, lipid profile and pro-BNP, and congenital, there is a echo. Microvascular health, the retinal, neural, and renal health is should be screened, and comprehensive dilated eye examination, that is fundoscopy, then monofilament, and for renal, look for the microalbuminuria and BUN. Then viscerometabolic health, there is organ specific, mitogenic aspect of metabolic health. Organ specific is hepatic health, non-alcoholic fatty liver diseases, that is ALP and GGT and fibroscan score, and obstructive sleep apnea. Second one is, that is sleep studies are needed, and gonadal health. For gonadal health, there is imaging and hormonal assay. Then mitogenic aspect of metabolic health, that is malignancy, acanthasis nigricans, and skill tax. For malignancy, clinical biopsy, acanthasis nigricans biopsy, and skin tax biopsy if needed. Next. So the first gliptin studied in India in diabetic patient is Z10, Z1020, and Z10M. In newly diagnosed type 2 diabetes patient with HbA1c reduction, that is less than more than 7.5%. So these are the top TIR study result CGM parameters, which shows the conclusion that teneligliptin effectively reduces glycemic variability in patients with type 2 diabetes mellitus. Then these are the study in CKD patients. To evaluate effect of teneligliptin on renal parameters in type 2 diabetes mellitus patients with CKD. So top renal study summary of finding is severe renal impairment in patient did not affect the renal function. Severe renal impairment patient improved glycemic control. Teneligliptin was well tolerated and not satisfying concern were reported. Results of top renal study correlate well with international data on teneligliptin and linagliptin. Thank you.
Yeah. Now, thank you, Dr. Akshay Shewale, sir, for sharing the insights on teneligliptin as well as the comorbidities along with the diabetes management therapy. So, sir will be discuss more about this complication and their treatments. So, behalf of Glenmarks, thank you for the Dr. Shewale, sir, for taking this session and share their expertise about this molecule. So, with this note, we will conclude this meeting, sir. Thank you so much for your time, sir.
Thank you. Thank you.
Thank you, sir. Thank you so much.
Yes, with your permission, we'll conclude the meeting.
Yes. Yes.
Okay, thank you.